episodes of vertigo, which are not very specific for pituitary adenomas. And she also had on and off visual changes, which we could not clearly attribute to the presence of pituitary adenoma or compression of the optic nerves. So that's why, even though she did have pituitary adenoma on the MRI, and there was some compression of the optic apparatus, since the compression did not appear critical, we decided to follow. And the repeat MRI of the brain at some point later, I believe a few months later, demonstrated that the tumor was overall stable. However, she started to have some more visual symptoms and developed what's called the scotomas, the dark spots in different parts of the visual fields. And again, since most patients present with some vision loss in the periphery, we did not feel that that was typical, but nonetheless, there was no other offending factor. And in the end, we were convinced that her visual changes were probably due to the compression of the optic nerves and the chiasm by the growing tumor.
Okay. At that point, the decision was made that it was substantial enough, or I mean, and I'm sorry, in more layman's terms, I guess, if you will, the tumor did grow from the 6-month period, from the first to the second?
No, the tumor did not grow over the past 6 months, and it was quite large to begin with, and the patient did have compression, and therefore we felt that the compression was the immediate cause of her visual problems.
Can you walk us through the surgery, what it entails?
So we decided to take her to the operating room to decompress the optic nerves and remove as much of the tumor as safely possible. And the diagnosis was quite clear. It was a pituitary adenoma. Not many things would look as typical as pituitary adenoma in this particular location. A surgery like this involves general anesthesia when the patient is completely asleep, doesn't feel or remember anything. In many such cases, we would put lumbar spinal drain to decrease the pressure around the tumor and decrease the chances of cerebrospinal fluid leak after the procedure. We performed these procedures with ENT colleagues, and it is kind of a team approach and a very good illustration of a team approach. So everything starts with good anesthesia to make sure the patient's vital functions are all stable and the blood pressure is maintained at normal level to ensure that all the critical structures receive adequate blood supply and good amount of oxygen. Then we place the lumbar spinal drain in some cases. In some cases, we proceed directly with surgery. The opening is performed by our ENT colleagues, and they would typically use an endoscope to guide us through the nasal passages all the way up to the sella turcica. This is the anatomical structure where the pituitary adenoma and pituitary gland is located. Okay. And then we operate using 4 hands. It is critical to have a very good ENT partner and build this relationship and partnership so that we would be able to remove complex lesions using adequate visualization, good knowledge of anatomy and anatomical structures around that. And also it helps to operate using 4 hands. As opposed to just using 2 hands like it used to be in the past when neurosurgeons would operate without the help of an ENT colleague. Okay. In that particular case, we went in and opened up the front portion of the sella. It was a bony structure that separated the nasal passages from the pituitary adenoma. Then We started by opening up the dura, the membrane that covers the pituitary gland and the adenoma. After that, we developed the plane between what appeared to be normal pituitary gland off to the sides and the pseudocapsule, the membrane that separates the pituitary adenoma from normal pituitary gland. Then we performed debulking of the tumor, sent some tissue to pathology, and then removed the rest of the tumor by pulling the walls of the mass into the cavity created by the debulking. And this is where the visualization of the structures within that cavity within the sella, where normal pituitary gland is located and the structures surrounding it are present, is really critical. So we use different endoscopes, 0-degree scopes and 30-degree scopes that are typically held by the ENT specialists to help us to visualize the surrounding structures well and ensure complete removal of the tumor. In the end of the procedure, we took the patient for an intraoperative MRI. And in fact, the MRI machine comes into the operating room over the patient, and we can perform the scanning right there on the spot without actually interrupting the flow of surgery. That procedure allows us to visualize the anatomical details as we go. It also helps us to see if there's any residual left behind. And I hope I'm not talking too much.
You're doing great. No.
All right, so
this is excellent.
And you know, let me tell you the story that became a turning point in my practice. I had a patient who was in his early 70s with very significant vision loss in the peripheral fields. And he came over to the office complaining of the vision loss and headaches. We took him to the operating room and did exactly what I described. In the end, I felt that I removed pretty much everything. And you know how surgeons may become confident. We've done that. We've been there. We know the structures. But in that particular case, the tumor was very fibrous. And removal of the tumor took a while. So it took me about maybe an hour to get very good decompression. And I felt at that point that everything was out, and I saw the pulsations of the membrane that separates the resection bed of the tumor from the optic apparatus, and I felt that everything was done as much as we could accomplish. We did an immediate intraoperative MRI, and I was not a believer yet. I thought that, okay, so let's see what happens. And then on that scan, we discovered that the patient had a sizable residual still embedded into the optic chiasm and optic nerves and persistently compressing the visual, the optic apparatus. So the conclusion was that the MRI is really invaluable, because oftentimes we can think that, okay, I've taken it out and I've reached the limit, but the tumor might be hiding somewhere there, and without the precise knowledge of the anatomy, and especially in challenging situations when tumors may be somewhat more vascular, more fibrous, or maybe if there is a membrane that separates the bulk of the tumor within the sella from the tumor that is in the suprasellar part, just above the sella, embedded into the optic nerves. That knowledge is really critical, and sometimes it can make a huge difference.
So on that intraoperative, they call it intraoperative MRI, correct? But it's actually brought in after you've done the bulk of the surgery, correct?
There are different ways of doing this. Some surgeons would perform several scans as they go, just to monitor the progress, whereas other surgeons would remove as much as they feel they could, and then they check and see if anything else can be safely removed. So that's our strategy, because each time you bring the machine into the operating room, You have to drape the patient, and after the MRI is done, undrape the patient. The MRI itself takes some time, so it depends on the number and the extent of sequences that we utilize. In some cases, it may be, may take as long as half an hour. The operating time really matters. So you don't want to make the surgery unnecessarily too long.
But okay.
So our strategy has been to remove as much as we thought would be the maximal extent of the resection, and then do the MRI and decide if we need to go and remove more.
In the case of Carol, when you saw the MRI was satisfactory in terms of
the MRI results were very satisfactory. We felt that a gross door resection of the pituitary adenoma had been accomplished.
Okay. And by the way, the procedure took, or the surgery took how long? Or roughly?
The surgery took approximately an hour and a half to 2 hours, something like this. And then add the MRI time, which is another almost an hour. So it was overall about 2.5, 3 hours.
Okay, and her recovery went. I know she mentioned she was, slowly the vision recovered. What do you recall from her about her recovery after the surgery?
There's two issues with recovery of patients after pituitary adenoma resection. One is the immediate recovery. Most of such patients are quite miserable after manipulation inside the nose.
Doctor, can you please repeat this answer and come back where you were? Because you just moved and laid back like that.
Oh, like this?
You just, yes, like the way you were, and start, yes, thank you.
Okay, all right, very good.
So in her case...
There are two parts in the recovery process. One is the immediate recovery from surgery itself, and many such patients feel congested. The nasal passages are very sore. There's excessive mucus production, crusting. They're packed and whatnot. And the recovery from that takes approximately 3 days to maybe a couple weeks. And then there's a recovery, there's a long-term recovery when their visual field deficits and hormonal deficits hopefully resolve, and that may take weeks to perhaps months. In her case, I don't remember exactly how long it took, but sometime after surgery she started feeling the improvement in her vision. And resolution of her symptoms.
She's, according to her timetable, it was fairly, based on what you just said, it was fairly on target, I guess, or fairly quick. It would be a little quicker for her to recovery in terms of the vision, especially she mentioned in the hospital was kind of a little fuzzy up, but she didn't have her glasses on. And then...
Some patients feel an almost immediate relief. The vision comes back, and at least subjectively, they feel that they can see much better. The dark spots are gone, and the visual fields widen. But that doesn't happen in every case, and it may take some time. And what I typically tell the patients that most recovery happens within the first 3 months after surgery, and then may continue to recover for up to perhaps a year, when in most cases patients reach the plateau.
Okay. But in her case, and by the way, the intraoperative MRI, is that relatively new, or has it been around a while, or has there been advanced?
The intraoperative MRI has been around for a while. Okay. We got our unit, I believe, about 4 years ago, and have used that ever since on a regular basis. And interestingly, pituitary adenomas are probably one of the indications when the use of intraoperative MRI is totally justified.
Okay.
It is very easy to miss a fragment of the tumor, especially in the area of the cavernous sinuses, or above the structure that's called the diaphragma sella that separates the the sella itself from the suprasellar part, and oftentimes fragments of the tumor embedded into the optic nerve would be otherwise missed. But intraoperative MRI allows us to detect it early on and just minimize the chances of this problem.
Is there any other real-time mapping that you during the surgery, other than the MRI at certain stages? Is there any other real-time?
We also utilize intraoperative image guidance. And this is a technology very similar to what people use when they drive. They use GPS, and we use the same thing for surgery. When preoperative neuroimaging studies are done, they are subsequently uploaded on the planning station of the image guidance machine in the operating room. And then we have the equipment to track the instruments, different tools when we operate. That gives us an idea of where we are anatomically to make sure we stay in the midline, avoid damage to the critical structures such as carotid artery during the opening. And it also allows us to get a very good estimate of the extent of resection. Nonetheless, this is a technology that is based on the images obtained prior to surgery. It doesn't give us a real-time idea of what exactly is going on. And sometimes the pieces of the tumor can be pushed away, and or we can push the equipment, the neuronavigational wand a little bit too hard, or the anatomy changes for some reason in an unpredictable way. And this is when the images obtained prior to surgery may become unreliable.
Okay. All right. Now, going to the pituitary tumors, I understand they're somewhat, I don't know if common is the word here, but most of them are benign, correct?
Correct. Most of the pituitary tumors are benign.
And is it safe to say, or correct to say, most of them do not present problems? Or, they need to be obviously looked at, treated, but what percentage of patients would require what Carol went through? Is there any idea in terms of the breakdown?
Pituitary adenomas are extremely common. If you take autopsy series, at least 0.5 to maybe 1% of the people would have pituitary adenoma, at least microadenoma, the small size pituitary gland lesion. But the vast majority of these patients obviously will never have any symptoms and would never present to the surgeon's office with any particular complaints. This is a situation when size really matters, and larger pituitary adenomas might be typically associated with symptoms. And if patients develop some hormonal changes or some compression of the optic nerves and present with vision loss, in those cases we operate. But this probably would be a fraction of the patients that harbor pituitary adenoma.
And so, vision problems, as you said, are one of the more common symptoms. But vertigo is not, correct?
Vertigo is not. Vertigo is not related.
All right, because you mentioned that was the first thing that told her that something wasn't quite right. But vertigo is so common and so, harmless.
If she only had vertigo, I would consider that an incidentaloma, an incidental finding. Okay. But a combination of this and particularly, even not the combination, I take my word back, but visual changes in the context of some compression of the optic apparatus, this is what made us think that this was a symptomatic tumor.
Okay, and you mentioned the key role of the ENT colleague that assists. Do we know the name? I'm sorry, we should probably get the name of the ENT who was part of the surgery as well.
We usually perform this procedure with Dr. Pernas. He is an ENT colleague who is very skilled in operating on the nasal sinuses, and he would perform the approach, and if necessary, especially when we anticipate a cerebrospinal fluid leak, and in cases when there's a large pituitary adenoma and we form very wide resection, or if this is not necessarily pituitary adenoma, because there might be meningiomas and chordomas and other types of tumors that present in this location. He may develop the mucosal flap. This is a local tissue flap that is utilized to close the defect after we remove the tumor, to ensure good healing and a reduction in the risk of cerebrospinal fluid leak after surgery.
Okay. Is there anything else about Carol's case that stands out that we may not have covered? She was a very good patient, I'm sure.
Yeah, not that. I mean, I think her recovery was uneventful and as expected.
And that's a good thing, I guess. I mean, everything has gone smoothly. Is there a follow-up after a few months, or how does that work in terms of these kind of?
Pituitary adenoma patients are typically followed up by a neurosurgeon, an ENT, and an endocrinologist. Imaging-wise, we repeat the MRI about 3 months after surgery. I'm sorry, I take this back. Imaging-wise, we have the intraoperative MRI. Or if the intraoperative MRI is not done for some reason, then we do an immediate postoperative MRI that serves as a baseline. After that, we repeat the MRI in about 3 months, and then, since this is typically a benign tumor, we would follow maybe with imaging studies maybe every year or so, depending on what the previous imaging would show and how the patients do clinically.
And it's very rare for there to be an issue, follow-up issue of regrowth or is that very rare?
Some tumors can regrow, and especially larger tumors. There are studies that show that the regrowth rate can be as high as 40 to 60% in the long run. So if you follow them up for 5, 10, 15 years, that's why in some cases, especially if there's a clear residual, we elect to add radiation therapy to the resection bed to stabilize the tumor and prevent the growth. That's why it is critical to remove as much of the tumor as possible. And the intraoperative MRI and the utilization of endoscopic equipment with image guidance play a key role to ensure that good resection is achieved.
So up to like 50% is potential regrowth over the following years.
Over the following years. Yeah. These tumors are benign.
Right.
And you're not going to see the regrowth very rapidly, within a year or two.
Okay.
In most such cases, if the tumor grows back, it happens over a long course.
Is there, to your knowledge, is there a typical age group category here for these type of tumors? People, folks in their 50s or 60s, or is there an age?
You're correct. Yeah, most patients are in their 50s to 60s. But there's a subset of patients, the subset of younger patients who may present with pituitary adenomas. And in many cases like this, the adenomas are aggressive, grow in different compartments, tend to grow back quickly. We've had several patients like this when tumors are very resistant to treatment, and we utilize different technologies and adjuvant treatments such as radiation therapy to control the disease.
And we're always looking for trends here. Is that a trend where you're seeing a younger subset with more intense or tumors?
Say it again, I can hear you well.
Is that a trend that you're seeing, a younger subset of patients for pituitary tumors?
No, there's no clear trend.
Okay. Gabby or Katie, anybody want to ask the doctor any other questions? Or Gabby, you're on mute.
Hear me well?
There you go.
Can you hear me well? Dr. McDermott, when we met with him, he mentioned that the intra-op MRI post-op is something new that we're doing. I guess normally before we wouldn't do it intraoperatively, we would do it post-op. Is that true, or did I understand that correctly?
Can you say a little? Can you speak up?
Yeah. Can you hear me now?
Yeah, I can hear you.
Okay, sorry about that. Dr. McDermott mentioned that we were, prior to this case, or prior to a few months ago, we were doing the post-op MRI, not intraoperatively. I don't know if that's true or if I understood that correctly.
No, probably misunderstood.
Because he mentioned something about checking for residual, that we would do that after they were outside of the OR. We wouldn't be doing that inside the OR.
Well, not at Baptist. It's probably something, you know, that he described. The facilities that do not have the intraoperative MRI, they would typically operate on the patient and then would perform a postoperative MRI. And in some cases, they would do it in a very delayed fashion. It would be done maybe 3 months after surgery, after the dust settles, to make sure that they would see not so much the postoperative changes and swelling and blood products that may interfere with the quality of imaging. And in that case, it's kind of too late, because you may not see the true residual, and then you have to, in the most extreme case scenario, you have to bring the patient back to surgery to reoperate if there's a substantial residual. Since we started utilizing the intraoperative MRI, you know, over the past few years, once we got the technology, this has not been the case. We would always perform the intraoperative MRI intraoperatively.
Okay, perfect. Thank you.
So just to clarify, Dr. Siomin, there's nothing new happening then with intraoperative MRI. It's kind of the same as we've always done it since we required the technology back in like 2014.
Correct.
Okay.
Yeah.
Well, that was very enlightening, the whole
Doctor, can you just please do the part where you said that, Carol's surgery wasn't eventful and the way it was supposed to be, and she's expect to have a normal life again, like a little bit more complete, the sentence for a happy ending for the video?
In the end, Carol's surgery went very well, as expected. We did not have any intraoperative complications. We did not have any evidence of cerebrospinal fluid leak. We removed the entire tumor, and overall she did very well. We were very pleased with the outcome.
Fantastic.
Thank you.
Well, good. Doctor, this is great information, and as usual, we learned a few more things that we didn't know about. Anything else, guys? Is it? We're good?
We have everything we need.
Say again?
Thank you very much.
Thank you, Doctor.
Thank you.
We appreciate it.
Thank you, guys.
Take care.
Thank you, Dr.
Great job.
Siomin.
Thank you all, as always.
Bye.
Take care.
Bye.
Thank you.